very specific therapeutic recommendations based upon where you fall into your 10-year risk. And so we adapted the calcium scoring to fit into those categories to make it utilizable by the primary care
Help us
physician.
in our digits, how we go down through this digits. We said normal and normal. That means the profile, modifiable risk factor profile is normal, and your structure function test is normal.
No, by normal now, if we're saying 0, that's another issue than saying less than 100. Less than 100 is not necessarily normal. There's some finite risk
So then now we have to
associated
break it down.
with those
But
calcium
isn't that
scores.
why you said 70 or 70?
But even less than 75th percent is not necessarily normal, even if it's less than 75th percentile and less than 100.
Should we go ahead based
And I
on
don't think we should get into treatment at this point in time, quite frankly.
We don't have any.
It gets more complicated.
We don't have any use for this without having treatment. If you don't make treatment, you don't even. What?
Well,
this
but
is-
do we need to get into the specific treatment
No, at
recommendations
least
based upon the scores?
at least outline, and leave the part that is addressed by NCEP and others in their hands. We
But
don't
you
want it.
can't leave it in their hands because you're using it to modify the NCP recommendations.
No, let's see.
You're using it to modify the NCP
Pardon?
treatment
Let's
recommendations.
agree on, let's
No,
agree
no, we have to
Let's
modify
agree.
who to treat, not how to treat.
Okay.
Okay, you know what?
Yes.
Let's
Yeah.
come
Start
back.
And what
with,
goals?
let's start with binary, and then we go back to yours that is graded. Let's go with binary.
Negative,
Negative.
leave them alone.
Right.
That's
That's the
okay.
lowest.
Let's just go with this
What is
one.
that?
Negative test, negative profile. Profile means modifiable risk factor.
No
profile.
modifiable risk factors. Low, and leave
Low.
them alone.
What does leave them alone?
That means don't start any treatment.
No treatment. Come back
No,
in five.
no, no pharmacological.
Bring them back, leave them alone?
Yeah, come
5
back in
year
5
follow-up.
years.
For next 5 years.
Primary prevention guidelines.
Right. Primary prevention,
Reassess in 5 years.
reassess in 5 years.
Yeah. Well, these guys, their cholesterol is good. Good means by the guideline is good. And
What do
the
you do in 5 years, though? Do you go all the way back to here?
Well, we'll have to.
Yeah.
We'll have to
Yeah,
come back.
sure.
Yeah.
We'll bring them back.
We'll have,
Yes.
we'll have to bring it back. Now,
think so.
the other group.
As opposed, okay.
The other group that have modifiable risk factors, even though they have negative anatomy and function,
We're going to put
prudent
in
lifestyle modification to address the risk factors.
Exactly.
Depending on whether they're at, according to Framingham risk, whether they're at intermediate or high.
We don't talk about Framingham. We say your disease is negative, your risk factor profile is positive.
And therefore you may develop disease in the future. Therefore,
So go on the.
treatment is
What's your
Go on.
definition of a modifiable risk factor? Is an LDL greater than 190 a modifiable risk factor?
Yes.
Okay.
Yeah, well, let's just
That's
go
the clear.
exactly.
That's fine.
You
All
know,
right, so what are you gonna do with these
one of the
patients?
one of the problems with this,
Depending-
Lifestyle.
Lifestyle modification.
one of the problems with the risk assessment and the percentage risk is that it is actually not that people who have LDLs at a certain level have a risk of those at a different level. It just means that the fraction of people within that category
Right.
are at less risk, have no risk. If your blood pressure is over 160 over 110, 100% of those people are really at risk. They have early disease and they need to be treated. When your blood pressure is 130 over 80, there is now a dichotomy. There are some people who have the same risk as the people at 160 over 100, but there are a lot of other people who have no risk, and then we say, well, you're at intermediate risk. But you're not at intermediate risk. You either are at risk or you're not at risk. And you're looking at a mixture of people as you move into different categories. Now, the CIC score is a marker for disease. So you're no longer looking at risk of disease. You're saying this is the magnitude of disease. The same thing is true with arterial elasticity or IMT, whatever it is. So we get mixed up. And of course, when we say there's a different target for LDL reduction, that's a misnomer too. If being below 100 is the best for reducing risk, then anybody with disease should be under 100.
Right.
And people without disease don't have to have their LDL lowered at all.
In a binary fashion, you mean, or depending on how much disease they have?
Well, in binary would be like 0. If there's 0 disease, You don't have to have your LDL lower to below 100 or 130, or actually even under 160. But I know if you begin to violate the current guidelines, you get into trouble.
Right, yeah,
So you're
trivial
going to have
disease, you can't
to
justify
pay
that.
lip service to the guidelines. But intellectually, we would say, if you don't have disease and you're zero, then you probably don't have to do anything, whatever you're doing.
And all the tests, IMT and EBT, will need a threshold for which we're going to be
Yeah,
aggressive.
we're going to come back to that.
I realize that,
Yeah,
but that's
we're-
the exact point, is it has to become binary, unfortunately, because you can't give guidelines without it becoming somewhat
Right.
binary.
And maybe the guideline, if you need to be on a statin drug. I mean, I have many patients who come to me and say, I just read that my LDL should be 70, and mine is 105. And what is the answer to that? If 70 is really the best target, why shouldn't everybody be targeted for 70? What, you mean we don't have to slow disease in people at intermediate risk? Of course we
Yeah,
do.
yeah.
Because among those people at intermediate risk are people who are going to have an event, and they should then,
Right.
maybe
But
they
if you
should be
could,
at 70.
if you could define the idea of this, I think, is if you could define those intermediate risks, some of them as low risk, then it probably isn't worth the time, energy, or cost, or
Right.
potential risk factors of putting them on lifelong
Right,
statin therapy.
and that's
To
the
get rid of
problem with
below
the
70.
Framingham score, which
Right.
is not looking at disease.
Well, 40% are left in intermediate category, which is silly. 40%, the biggest population is left in the middle
Right.
of Framingham. Framingham defines a small population at high risk and a small population at low risk.
Right.
And leaves most of them in
Most
the middle
of the
for us to
people
have
in
to
the
try to flip a coin
Right.
for each individual therapy. And we're not doing a good job of it because we're not applying therapy to the people at the high intermediate risk. We tend to apply it to the low intermediate risk of people who want the drug rather than the people who need the drug. And that's our problem.
Matt, that part, Matt, has to go into
Right.
introduction where we.
Of course, but that's the most important
That's a
part of this whole
very
thing.
elegant argument that we need to really emphasize on that one.
That's the whole idea of this
Yeah.
stratification, is to sort out the stupid intermediate category to lower high and have no more
Now,
intermediate
here,
risk.
when we go, and now, again, we're gonna come back to RV later when we have more structure in next 4 or 5 minutes. We define the easy one, negative, negative, negative test, positive profile, lifestyle modification, aggressive lifestyle modification, come back in 5 years. Positive test, regardless of profile. We're gonna put them,
Sticking with the negative test, positive profile, are you going to leave somebody with an LDL of 220 on no therapy, even if they have a negative test?
no, I think we should just.
I know drug therapy.
I think we should agree with the guideline there.
Yeah, if they don't,
Okay, so it's not-
guideline doesn't say then treat them with
Treat
drugs.
them
Yes,
with
it
the
does. It
guideline.
does. If it's greater
Yeah.
than 190,
Yes,
just treat them.
yes. And 190 we treat them.
So it's not just no drug therapy, just let TLC. You have to institute drug therapy above certain thresholds.
We say,
Like hypertension.
Yeah.
But then what is the point of identifying a negative image?
Because the threshold is much higher. There'll be fewer people getting
well,
therapy.
see, you know that
Higher
there,
level of,
Higher level of LDL. 190
we
rather
know
than
that there are
160
not
or
too many of
130
them.
or 100.
And we know that when they have such a thing, 5 years later they might develop this. So you
that's
don't want
why
to wait.
this data on what happens to 50-year-olds with a negative but positive
but
risk
that-
factors in next 5 years would be so valuable.
But this data is not regarding the LDL effect, and we have enough data to say that if you have high LDL, you will grow. So I think it's reasonable to go with the guideline in that category if they are very high.
Right, and there's
to go.
issues of LDL and stroke as well, and peripheral vascular disease that we can't
Yeah.
ignore just because we have a clean cardiac test.
Well, that's why the CalCAS score is not the whole story.
Yeah.
It's not
But until the threshold has aggressively changed what they just said, that everybody should go with that. I think majority of our population with negative test and positive profile are not going to meet the criteria for therapy, drug therapy, and they're going to benefit from aggressive lifestyle modification, whatever.
But somewhere in the document, we made
We have-
clamor for data to support that treating the risk factor in the absence of disease does good.
That's a good point. To call for such a study, that's a good point. And then now in the group, the disease is positive.
Before we leave this, what part of the population would fall into that category of intermediate profile, not requiring treatment because the imaging is negative? How large a portion of the population would that be? Because if it is large, that will become an argument in this approach.
It's large.
Yeah.
It is going to be large because
Yeah.
you're going to have people with positive risk factors
Negative scans.
and negative scan. It's
Yeah.
going to be large.
Yeah.
It's probably going to
Exactly.
be. It's going to be probably 30% of population because about 50 fall in the negative risk factor, negative test,
Yeah.
30 something here, and then 20% or 25 in the right side, which would be positive test.
It's going to be half of the average 50-year-old and a third of the average 60-year-old.
Yeah, exactly. So I mean, that's a very powerful argument for this particular approach.
And that's
And
why,
when do
that's
you-
why we could make the argument, because it will eliminate 50% of people who now
Now
don't
we
need
don't need
therapy,
therapy.
objectively, for the next 5 years.
Right.
5 years.
Exactly.
Yeah.
Perfect. Now the very
I think that the critical question is going to come, I think that the people who have zero score are going to save a lot of money, potentially, of unnecessary treatment.
Right.
And if
And
they did
unnecessary additional testing.
Yeah,
additional
so
testing.
over 190 LDL per day, we'll treat them, and over definite hypertension treatment. But the question can come in, at what level of atherosclerosis, we're going to define atherosclerosis now by the imaging, are we going to say you need to be treated? So I think we'll probably
No, we just talked about it. We just
Well-
talked about that threshold. We have to address that in another
another time.
chapter
Okay,
of that.
That's what that table was designed to address.
But-
yeah, I know, but I
but
think
See, what-
that's difficult.
This is like
And-
building the whole structure, and that threshold is the chip that every time you can easily, based on the studies, put it up and down. But we are building the skeleton, which makes a lot of the job for us. If the test is positive, regardless of their value of profile,
At the threshold.
we want to pay attention to them. Now, what is the pay attention? Is
Lifestyle.
lifestyle.
And aggressive cholesterol lowering.
If their cholesterol is
You're not going to lower normal blood pressure. You're not going to lower normal blood sugar.
But
Now,
what's
what's normal
aggressive?
blood pressure?
Well, again,
Aggressive blood
110
pressure.
over 70. You're not going to treat at 110 over 70.
no, what he's saying is what about 132?
No, but 130.
Mine runs about
Yeah,
90.
but most of them are 120 over 80 or up.
Understand, you can define a certain threshold, whatever threshold you're going
But-
But we're using ACEs and ARBs to treat patients who are 120 over 80.
Yeah, but not 110 over 70, or
Well-
90 over 70.
One day they're
You'll have a lot of
110 over
sympathy,
70,
yeah.
one day they're 124 over 81, you know.
So if the disease
But
is
that you
positive,
can define, that you can define at what limit you're willing to treat a risk factor.
But I think that the definition of positive, whatever threshold it is, means aggressive blood pressure control and aggressive
Lipid
cholesterol
control.
control
Blood sugar.
and blood sugar.
so because the disease is positive, we want to be aggressive here.
Right.
And if they have a reason to be aggressive, like high cholesterol, high blood pressure, is great. If we don't have, we're going to be aggressive,
Lifestyle.
non-drug therapy lifestyle. We want to be aggressive here, and then we want to push, probably with scientific arguments, some of those thresholds, because those thresholds of therapy, risk factors probably are not correct. That's why these guys have disease.
But I think these are drug therapy. I think you said non-drug therapy. I think it is going to be drug therapy. Even,
If they
Drug
don't,
plus lifestyle.
Yeah.
Because
Well,
lifestyle has
but
independent
if they don't have high cholesterol,
doesn't matter if they got after
No, if they got atherosclerosis, you
Any
treat them
cholesterol
statin,
is high.
whatever their level
Yeah.
of cholesterol is.
Any
Any
cholesterol is high for them.
Yeah.
If they have disease, that's the whole concept.
okay, and we
Is that
should
they
we
have
go-
developed disease with an LDL of 80. That is too high for that.
Yeah,
That's the
but,
hypothesis.
but you're making a case for statin therapy, which is not cholesterol lowering. It's other things.
Well, I think it is still cholesterol. Though. I don't buy this pleiotropic nonsense.
Okay.
I
Oh,
think it
gosh.
is less lipid modification.
You know what? We just called this meeting fight against the whole world.
Yeah, I have no faith in pleiotropic concept. No. I think statins work by lipid modification.
Well,
There's no clinical data to say otherwise.
I don't think it matters what the mechanism is. The idea is that but
We're-
what's being proposed here is being aggressive
okay.
about
See, I did that in a second.
which means to an LDL of less than 70 with atherosclerosis.
Okay, a positive test with LDL 70
Then you look at HDL triglycerides, Lp(a), homocysteine.
Above a
and
certain
other-
level, though.
But you don't have to pick a
right,
target,
that's
because
what I said,
the new
that's gonna be
guidelines
important.
say.
It can't be just binary.
Right,
So,
but you don't have to pick
I
a
said
target.
that's speaking.
Okay, well, we have to say we're gonna do therapy.
Institute statin
Right.
therapy.
Yeah.
That's what the guidelines now say. If you have a heart attack, you don't care what the LDL is, you institute that statin therapy because
Okay.
your LDL is too high. Whether you think it's pleiotropic or LDL lowering.
Right.
I agree with PK, I think it's all LDL lowering, and I think in that person,
Lipid
lipid modification, 80 was too high for
So
that
if your
guy.
test
Not
is
a heart attack.
You
positive,
don't have to measure the, you just treat with a statin.
But you have to measure only because you want to
Follow,
track whether
follow.
the therapy is
Yeah.
effective.
for follow-up.
Because
So,
some people
I
don't
You know, in the
respond
ASCOT
Yeah.
trial, they all got 10 milligrams of Lipitor and it saved lives like crazy.
No, I understand, but there are patients who are going to be statin resistant or statin unresponsive. So you need to have a baseline lipid level to know whether your therapy is actually modified.
Plus, if the value comes out
Maybe
very
it makes
high on
the
your initial level, you gotta be
long-term
more
effects,
aggressive.
even though the Lipitor.
No, we have to measure.
Don't forget, you don't want to be in LDL jail like that. You want to, don't forget the HDL.
Yeah, well, yeah,
That's why I say you
but-
look at
now-
LDL triglycerides, look at other-
Pfizer hasn't come out with their drug yet, we have some time.
We want to measure the risk profile, which we mentioned as modifiable risk profile, and implement therapy regardless of
the level of.
I mean, this is going to put us in a very contrast with guidelines.
But that defines high risk. We're talking about high risk category.
It's not.
You're not going to
Well,
say.
not really. No, that's the discussion right
I
now.
don't think you can do that. You can't say somebody who has a calcium score of 2 should.
No.
should have their-
I'm,
You're just
I'm
going back
looking
to
at
the
someone who
threshold.
3 years ago got up in front of 300 people and said, if a calcium score is 1, I'm going to treat that patient aggressively. It happens to be Harvey Heck.
I didn't hear
San Diego. Any calcium.
Yeah.
Any calcium.
No.
And I happen to actually agree with that approach. Because
Okay,
if you have any disease, it
no,
is-
Harvey, we have to come up with the definition for threshold. We have to really, threshold is really hard.
Well, that's why I
agree-
showed that table.
Yeah, let's agree with the outline, and then we'll go back after lunch, start to talk about.
You know, the difference between discussions of guidelines in Europe and America is that in Europe, you raise your hand and you're heard. Here is a question of how loud you shout.
That's true. That is true.
Oh my God.
So I just want to say one thing. And that is, I think that the concept of negative vessel pathology and risk factors and modifiable risk factors. If that's a large portion of the population that gets into that category. And one way of selling this document that we're working on is to say that we're addressing the problem of over-medicalization of society, and that we want to expand that picture. We want to expand that group. For the time being, we don't want to leave people with LDL over 190 untreated. But the data may come out that would be admissible. Perhaps you could increase it to 200 or 210 or whatever. But we're introducing a concept that a large population group will not necessarily will not need to with drugs. Yeah. So
Why is that? You mean their disease is negative?
Right.
yeah,
But the disease is negative, but they have the chance to develop disease if they have risk factors.
But
Sure.
that's why you're saying you're putting the threshold higher.
Yes, in 5 years.
But if we introduce this concept
Okay.
as a way of preventing over-medicalization,
Unnecessary treatment.
unnecessary treatment.
That's a perfect one.
And these are limits that can be contracted.
That's a
expanded
perfect one. This is
as more data accumulate.
And I want to add to that one that there are probably other tools coming to our aid in this approach. For example, if this test, what is, Mike, you can help me with that, the statin resistant versus like aspirin resistant, aspirin response. If that test come in, or other tests that can help us further find out or deliver our therapy, we can write in our discussion as a special consideration. Those will be even more appealing to us because unnecessary therapy will go down, and that would have some positive economic effect
Exactly.
on our economy.
Exactly. So I think that in line with what you say, Jay, I think the important thing is to keep this document generic. That we're we want to focus on the principles, not the details of either visual of imaging or the details of biochemical assessment or whatever. Another thing that I think we just ought to just discuss is, this is an American document, or do we want this to be one addressed at Europe as well?
We want to be European as well.
Yeah, so in that case, we should not talk about framing it, we should talk about global risk assessments.
We don't have framing at all.
So, risk factors.
We just say risk factors.
So we want to make
We
it
don't even
generic.
want to say
Good, good. We want to make it generic in that sense also.
No, we're going to change. That's what we're here. After this, everything will change.
Pyramid is going to blow up.
Yeah, we're going to
Blow it up.
we're going to blow up the pyramid in any way that's possible. I think this was a great before lunch meeting. We're going to break for lunch. Lunch is going to be in the conference room right across this room. In the meantime, we're going to think more and be prepared for our afternoon discussions. Thank you very much.
So you understand the Rasmussen Center screening test for early detection. First evaluation is 7 tests. And the arterial is a post-contra analysis method. If you're not familiar with it, I can explain that to you. I know PK is doing this in his place. We found this to be the most user-friendly and sensitive way to pick up the stiffness of the small artery. And large artery, small artery stiffness is predominantly endothelial dysfunction. Large artery stiffness is predominantly structural changes which occur over time. And it's a very sensitive and simple way. It takes only 5 minutes to do this. Then we do a rest and exercise blood pressure response, and the magnitude of rise in blood pressure with 3 minutes on a treadmill is a very sensitive identifier of vascular abnormalities. We do a retinal digital photograph, which is really looking at the small arteries in the retina. We do a urine for microalbumin, which is small arteries in the kidney, of course. And then we do IMT, the gravity, which is a large artery disease. So we're both assessing large arteries and small arteries by this methodology. And then we do an ECG, a cardiac ultrasound, looking at dimension and wall thickness and mass and all that function. We do a plasma BNP for early detection of left ventricular dysfunction. These tests are in total 1 hour in 1 window. So it's a very efficient operation. How's the times? Of those 10 tests? Arterial takes probably a total of 10 minutes. The treadmill test is a 5-minute treadmill test. The cardiac ultrasound takes about 10 minutes. The carotid takes probably about 10 minutes. So, when you go from one set of the instruments are all there, it takes somewhere about an hour. And then the doctor will spend an hour with a nurse practitioner going over an entire history, physical exam, and family history, and lifestyle, and diet, etc. And then going through, as part of that 1 hour, they also get these measurements made of their blood. It's a fairly comprehensive assessment. Who operates that for the patient? Who sits with the patient? The nurse practitioner. A doctor doesn't sit with them and go on all the tests? The nurse practitioner does. Nurse practitioner is wonderful, much better than any doctor I know to really sit down with the patient. This is during the testing. We have an extensive report afterwards, which goes through each test, explains what each test means, explains what their data indications, explains exactly what they should be doing, and that goes to their primary care. All the levels and all the women's stuff, and all that stuff, and an extra test that you like to sign. And then and this is when they go after for acting on. So, of course, is not part of the sizing. No. Who pays for this? Insurance. Insurance will pay for this. And I think the rest of the last time the last practitioners came canceling after the going back to Washington. The most practitioner counseling is all as a result of school. Because they get a written report, they don't come back up for any subsequent report for what to do. They're going to spend an hour talking about their diet and their lifestyle and et cetera, et cetera. So that all gets integrated into their eventual just walk it. This one's good for you. You have any study data on the estimate about the quality that you get to these tests every time you get a good every time you get a good echo, it's actually going to bringing back and redoing it. We have patients who have come back, and we've now got an intervention trial going on, so they're coming in with 6-month intervals for complete retesting. So we'll have some on the reproducibility, but you're right, I mean, anything else with limited methodology. But we'll have specific tests that's done to inform the average, right? Yeah, regularly. It's systemic. It's just a bit this is the sample with hypertension diagnostic. This is hypertension diagnostic. That's why they give one of cardiac resistance and some of the reproducibility data, right? And you compare that out to study there, the reproducibility is really very good. I think each time measuring blood pressure, blood pressure is more. That's true. But what's the most sensitive part of the measurement the abnormalities that we see, and that's the I can't see BMI in everybody, but yeah, we do the respiratory ratio, we do all those things, but they're not in a disease because they're not disease. I would tell them to start to lose weight. That's one of the things we're trying to do. But it doesn't influence the presence of disease. Each of these science one of the branches, I guess, is atherosclerosis. That's the Ryan series. Because other forms of vascular pathology. It's the linking of and atherosclerosis. I mean, I don't know whether IMT is atherosclerosis. It's aging of the clothes. Patients who have IMT. Yes, they have IMT. Yes, there are patients like that. What IMT indicates in regular function, when they're not necessarily. Your score score if it is abnormal. So you 7 tests here, and that's a total of possibly 14 points, and 3 here, which would give you 20 points. If every was abnormal, you get 20 points. We've never seen a 20. But the scores, there's 300 or 400 patients, now up to 1,000 patients, and I haven't updated this slide. Some idea of the scores. 0 and 2 and probably even 3 we would consider minimal disease. 0 disease. About 6 or above, we've arbitrarily decided these are people who should be treated. Now, this is all arbitrary, but I think the higher, the more likely you are to have an effect. But do I know that yet? Not entirely. No, we don't have the data. But it just stands to reason that there's going to be a link between the severe disease and events. The scores of 10 have no IMT. But so the IMT is not the gold standard. It's one of the markers that goes a whole. Well, don't you have to be avoided? I don't know how to wait. But you have sometimes data. Therefore, we can avoid it. I think the same score to a different ways. The rather than the outcomes, what makes best work? As an outcome of high blood pressure, and I would consider more than high blood pressure. Yeah. Because that's just a bad effect. I stand out and a clear differentiation between normal and abnormal and everyone else. Now listen, it's a wide distribution. But everything increases in patients who have normal blood pressure, but when they get on the treatment, blood pressure goes up to 200. And that 200 is hypertension. These people are walking around hypertensive most of the time, but when they sit down and work, which is the stupid idea in medicine, that when we've been talking about that is when somebody has been sitting carefully to rest for a period of time. Makes no sense. It's not about the response to that. Neurologic data is on blood pressure. Which is more important. I don't know. I found for yourself to probably don't wait. This presentation brings out the problem that there are different kinds of vascular pathology, and different parts of the arterial trunk that can be diseased. And the choice of methodologies reflect, of course, interest, but there are also a reflection of the balance of concern of there is many athletes relationship to concern. Which might replace somebody by residency scheme. Or choice somehow comes out to be a balance of concerns about various kinds of vascular pathology. So it doesn't make it less complicated, I think. I think this... No, it's just... He's not putting it forward. I think from the background, because you've managed a lot of heart failure patients, and you could be in people for... The women could be in people, right? We don't just put people... 9% of people have... ventricular dysfunction, and that's been shown in a variety of screening program, that there is a fair high incidence in the general population of undetected LV dysfunction, and most people have a higher risk of death. They are prone to hypertensive patient, right? They're not necessarily, some of them are hypertensive, but some of them have had silent infarcts, and they've got now LV dysfunction. We're finding a more to that than we thought, and that may be the population that we've looked at. I think there's for the first 300 patients, we did ankle brachial index, and we threw that out because there were, I think, one abnormality in the first 300. It's a very fast disease for healthy people, so we dropped that. And trajectory. Now, there is in this, obviously. This trajectory places people into low, intermediate, and high risk, and I just put an example in at age 40. Everybody, when they're born, must have a 0 score. So you have 2 points at age 40, and we can sort of identify what we think is a different trajectory. The theoretical threat for which you have an event is obviously fallacious, because events will occur in a way with acute plaques and things superimposed on small plaques. So obviously this is oversimplified. But if you only could identify a population that had a very low score, 2 or 3, you would assume on a low trajectory and are not likely to have an event until after age 100 and wouldn't intervene on that. So that's a very difficult. It's just arbitrary. Linear when things go through this. So it would be nice what we're trying to get grant support for is to bring everybody back at 3 to 5 year intervals and track their trajectory and then track events and see if this will be a more sensitive marker than Framingham score. We don't know that yet. So I'm putting them up. But I think this is, to me, the future that we should be aiming at, because it actually tracks the biological process rather than looks at risk factors. What's the last position? That's a difficult question. The problem with the tests in this screening clinic have CPT codes. And the CPT code has to be charged to be insured. They pay probably about 30 or 40 cents on the dollar. So what they pay is nowhere near what the charge is, but the charge has nothing to do with the cost. CPT codes for these tests come out to about $1,800. The payment is probably closer to 500. When we ran it ourselves, when I opened this clinic, I had funds from the Grateful Patients Foundation. Name, not surprisingly, was Rasmussen. And I remember I wrote myself and we would charge the patients to come in, and I calculated that we could actually make a profit if we charged $500 per patient for the whole battery of things. So patient costs $500 and you take the rest? So now you can't do that because the institution took this program and they allow us to charge the patient $500. It's just that they have to be charged the CPT codes, which add up to $1,800, and then the insurance company pays. Patients not providing communication for does not charge for the retinal photograph because we don't know it's justifiable. We charge for the arterial elasticity measurement, which gets well reimbursed for. The collateral, we do not charge for, and we won't do that ourselves, so it's very complicated. And it doesn't pay off. So, we don't pay because they don't offer preventive services. Now, there's a second cost to this is that when a patient comes in and we discover their blood pressure is 140 over 90, we check hypertension and then they're reimbursed for it better. So it's all patient screening when they don't have a diagnosis. So it's easy to many of these patients to find a diagnosis that will improve the reimbursement. It's complicated around the system very often. And I think this has to be, we have to really work through the whole healthcare system eventually to do this. This is one way the radar screen have to do this one center, but if there were 100 centers around the country doing this, you can be damn sure there would be room for the radar screen and there would be some intensive discussion about what you go for and what you don't, and how you reimburse it.
Well, thank you. Around discussions of this is looking switched on trailers to 55, 45 amount and 55 down from male and female respectively. If we saw an imaging function, structure/function assessment, and we'll have some actual test of them. Probably limited and negative. So that would negative, a positive test, and regardless of the risk profile, the risk profile, not therapy. Our therapy will be fairly right? Which fairly guidelines and guidelines. They switch a patient from primary prevention to secondary prevention. Primary disease. Okay. I'm thinking that's something else. There's the law. What they're going to talk about, how we define that. It's probably the thing that just learn. Some people will try, but we couldn't make that more likely acceptance to guys that the disease is positive. What percent of these people are not high risk factor? Not according to this food is how much more than 20%? Well, we have to define what is the risk factor. What we have is considered a risk factor anymore. And then if that's a risk factor, what level of that we are, which we are. Anything above 70 is a risk factor. Anything above 70 is a risk factor. 100% of the factor. If the imaging study is negative and for that person it is not yet an identifiable risk factor. No, it is positive. The OGS segment is going to say MCL over 100 translates to secondary prevention criteria, coronary disease or for coronary cancer. It doesn't talk anything about percentiles. That was rejected. It was originally thought that it was rejected because they thought that would open the door to the measurements more deep on the human we jumped a little too quickly away from Jay's presentation because it might be what the message that I got was that it is very more complicated than we have been. Our talking is going to be very simple because we're not talking about a union vessel, kind of vessel, it's quite evident that there's several kinds. Some of them are also related to lipids, disease, but some are probably more closely related to hypertension. And rather than sort of ignoring that, problem. I think we should, just in generic terms, say that our document has to address that issue, and so that there's a possibility for differentiating between these various kinds of concerns. And that perhaps we should say that the test for vessel pathology has to somehow reflect insights into the various pathologies that are important. We want to address atherosclerosis, certainly, but we want to have something that effectively addresses large vessel atherosclerotic disease. We want to have something that addresses, perhaps, and you have to say this, because jovial artery is contour analysis, post-contour analysis, does that reflect accurately hypertensive, small arterial, medium arterial disease? Well, and are we also concerned about capillary pathology, vascular diabetes, and light travel, and so forth? Do we want to address all that in the vessel assessment that we're talking about? What should be the principles for choice of methodologies in vessel pathology assessment? Can I have one more question to you? What is good about doing all the additional tests that are done? Can you start down with the first test? What's the next additional challenge? The test actually identifies all of the patients who need to be treated. Now, when I say you should be treated, it's philosophical because we don't have data that may well turn out. And if you suggest that if people have a normal blood pressure, then none of these other tests help because they're not going to need treatment. But I have a bias that, in fact, the blood pressure is a very poor guide to who is at risk. Lots of people with more than half the infarcts occur in people who have normal blood pressure and always have normal blood pressure. So blood pressure can't be a very good marker. The arterial elasticity, I didn't show you the data, but we have very nice data that the small arterial elasticity is an independent predictor of outcome, above and beyond aging. Aging is a predictor, and so is small arterial elasticity. The large arteries don't actually track. They're predominantly aging manifestations, not specifically disease. We think the small artery is largely dependent on nitric oxide and on endothelial function, so we can pick that up. Is there virtue in knowing who has endothelial dysfunction at the age of 40? Because I'm confident they will have a higher risk of an event, but in fact, is it discriminating enough to justify finding it, or should we wait until they get calcium in their coronaries, which is a later marker for the fact that these people had endothelial dysfunction at the age of 40, and now they've got calcium at the age of 60, and now we intervene with therapy? Or would we have been better off starting therapy at age 40 when we found the endothelial dysfunction? The blood pressure rise with exercise is very closely linked to endothelial dysfunction and structural changes in the large and small arteries. So that's, again, a marker. Pulse pressure, nobody's even talked about pulse pressure today. That's the hot, simple marker. What is it? It's obviously either sensitive or specific, but people with wide pulse pressures tend to have stiffer large arteries, tend to have aged vessels, tend to have higher event rates. And it isn't a risk factor. Some people have talked about trying to reduce pulse pressure as therapy. Well, that's foolishness. It isn't a risk factor. It is a marker for advanced disease. We find very highly sensitive in non-diabetics, microalbumin, albeit it probably isn't a single measurement of a spot urine. There's not a very precise way to do this, but we find that it's very closely with small artery elasticity, with blood pressure response, exercise,
so that it is telling us something about the small arteries. Now, do all tests add something to some single measurement? And I don't know. And that's what we have to find out. But let's again, so you're doing in terms of outcome? Yeah. My question, you're studying various vascular breaks, and what would be the outcome? That's what we need to account. That's what we need to know, and as we collect data, and I would be delighted if anybody around the table wanted to join us and collect the same kind of data in their own institution, because there's going to be power actually in the numbers. But right now, I would agree that we don't have adequate outcome data on the totality of the tests. But as outcome data with individual tests, we know the influence of blood pressure. There is some data on blood pressure rise with exercise as a marker for high risk. We have the data on small artery elasticity. We know microalbuminuria is a marker for event rate. So each of these individual tests have actually been identified as sensitive predictors of outcome. The growing question is whether adding them all together gives you more precision, and I don't know the answer. The cost is also a feature. Well, the cost is an issue. It's cheaper than putting airbags in your car. We'll have to, so we don't have to switch to the discussion. We'll stop to let's just finish with that. But treatment that pre-cancers that limits range of pressure for pressure makes it according to that from there. Do you want to diagnose or we just say it's not? I'm not saying that we're going to diagnose, but that was the symptom that I'm not I think the level to Australia is we must have not with a score over 6 goes on cholesterol. I'm not sure the question is not. I think there is, Brian Gray is a very good science in which they argue that cholesterol about that's going to be the end of the century. This was so much facetious much earlier in science, because one is discussion of what biological cholesterol is, and one on experimental cell studies, and one represents the other receptor. The numbers because the cell begins to synthesize LDL receptors. So the idea was that anything above that was likely not so physiological. That's what we got to think about. It's about significant. That's something. After the moment, but anyway, there was an argument that there is a physiological concentration of potential, and it's very low. It's very fine, but the goal suggested by the Code study, which is about 7 close to physiological, what Brian Wilson was talking about is physiological cholesterol levels, and the other levels in which we're going, and many animals live all their lives with those levels. So I think it's a hidden question. But we can aggressive
based on which guideline for secondary prevention, guideline for prevention. We should consider our highest. Rather than desensitizing or not, that makes a lot more sense. If I wish people, then I'm going to be lucky, which makes it if they're less than 70. So how worse that based not only on the and what's physiologic, but I think overall guidelines for which whatever else we have to say, these are the ones in the box. I think I would not want to do that way we are not in high risk. Guidelines are most categories. High, moderately high, moderate, lower. That's when you're incorporating this approach we were talking about. Lower risk, medium risk, or high, or very high risk, can be incorporated and then translate to treatment guideline. That's the table that I showed. It's an attempt to do that. Yeah, that's one version of it. I think you can do it though. I mean, you incorporate imaging now to say that they're higher risk. For some function and structure, we're going to say, well, that's one. It's abnormal and that's very high risk. I saw that a little bit before that. They also use the word disease by imaging. They just put definition high risk. The first step to reduce the stress. Now, when we go to that, when we can come up severe, very severe images found categories, the non-medical health, and lower about it's a good that's I think we can very close. Yeah. We can come up with the same thing. Now, I think we can just such an hour. Then we can come back and force and say, to not fight, we're going to almost downhill and positive test. But one of the positive tests is the calcium score of 90, or else with the calcium score of 150, we all come back to using the imaging is to get away from the population-based concept of the normal LDL and translate it to individualization. So, what people say is something I've been saying for some time. When is that level we should have not resolved? By definition, we consider aggressive therapy as could be both I understand curious is one of the in the same with gas and images. So we may really be debating at what point you are practicing secondary prevention. Apparently, guideline now says if it's on your score, the calcium score, that you're now secondary prevention. And we might expand that and say the presence of significant vascular disease as defined by the calcium score